Analyze your practice to determine how you can increase revenue. There's several things here. Look at your coverage, and different groups have different philosophies on Medicaid, Medicare versus third-party payers. But just make sure that you have you understand the market and that you are making the right decisions. You are moving along the track that is going to suit you best, and that it's not an emotional reason why you are doing what you're doing. Look at your practice itself. Look at your facilities, your staffing, your providers. Do you have the right ratio of provider to staff? What we find in studies, and especially the bigger the group, the more efficient they are. But the smaller groups will have maybe up to 4 or 5 people per staff. Well, what is the going rate without billing? It's about 3. And so, that money all comes out of your profits. So this is a good time to analyze your practice and whether you are fitting the proper benchmarks. Look at expanded hours. This is a big thing. Not quite as lucrative. I mean, when you expand hours, you have to expand personnel. So you have to sort of do a little bit of a survey of your patients to find out if they want expanded hours, because it does cost money to do that. But some people, and when we did our surveys, we found in women that they like to go from 7 in the morning to 7 at night, and they like Saturday mornings. But they do not like later at night, and they do not like Saturday afternoons or Sundays. That was just, and that's a few years old now. Look and see if there's additional service you can supply, and also look at your collaborative practice. And I'll show you some interesting data from Texas physicians about non-physician providers. Analyze how you can increase your revenue. Always be looking at your administrative and billing procedures, and certainly the bigger groups constantly do that, but some of the smaller groups don't do that, and they find they might be paying much more than they need to be paying for that. Assess your practice policies for co-payment and co-insurance, and also, although these all cost some money up front to put in, they do save money in the long run. Collaborative practice has been something that has not been well embraced by physicians in Texas, but certainly there are, everyone talks about the fact that there's not enough primary care physicians to handle these 40 million new patients. Well, guess what? There probably isn't, but who's going to help? It's going to be the nurse practitioners, the nurse midwives, the PAs, and so on. Accessibility of your group to ensure that you're practicing high-quality medicine. And this is one that the doctors have not done very well. Most groups do not have very good quality parameters in place. Do you and your group have a peer review where you review each other's charts, for example? Do we ensure that everyone in your group is not all practicing the same, but they're practicing high quality? Because these benchmarks are going to have to be reported on an individual basis and a group basis to the government, who will then put them on the internet, as I said, by January the 1st of 2013. And physicians are very reluctant to critique each other. But that is where it's at. Peer review amongst your group. And if you may be surprised what you find. And if you've got somebody really practicing very bad medicine, and their report card comes up with the cesarean section rate of 75%, that has an effect on everybody else in the group too, because patient knows in that group they've got a 1 in 12 chance, 15 chance of getting that doctor to deliver their baby. So it could have a dramatic effect. So this is an area where physicians have been notoriously bad and continue to be notoriously bad, and you almost have to bring somebody in from the outside to help you with that, because it's very hard to be objective when you're doing this. The partnerships with hospitals and medical groups, the days of practicing by yourself are over. You will not be able to afford to practice by yourself very much longer. You've got to supply all these benchmarks, do all the things to be in compliance with the law, and unless you're part of a big group, you just can't afford it. So this bill will put the final nail in individual practice. Whether that's a good thing or whether that's a bad thing, you could debate. And I think there's arguments that you can make both ways. But the reality is those days are over. What is even more of a reality that physicians have to come to grips with is the hospitals are going to be your partners in a major financial way. As much as many physicians and practice administrators cherish the freedom that we have and that we've historically enjoyed, the whole delivery system is going to be based in the future on a coordination of care and collaboration, including the hospital part. The alternative to hospital-physician collaboration is for the state to just take it over completely and tell us how to do it. It's going to happen. They're giving us a chance to do it, but if we don't do it, they will set up a system under which we will operate. Well, how do you do this? Physicians have operated extremely independently from hospitals. I hear when I give this talk, many physicians go, well, you're emphasizing the hospitals too much, because the hospital administrator told me that ACOs are run by doctors. Right, they are run by doctors, but who pays the bills? The hospital. And so doctors are notorious if they get a little bit of control, they think they're running it, but in fact they're not going to be running it at all. The hospitals now are going, and if you have seen what the hospitals have already done, does it remind you of what they did back in the 90s, Alan, when they all started hiring physicians? What are they doing now? Running around hiring physicians. Why are they doing that? The same reason they did then, to control them. And so what really is important here is that you try to understand the hospital administrator, and they try to understand you. Physicians are used to making quick decisions without a whole lot of thought into it. This is the way I do things. Hospital administrators, you've been to hospital meetings, they sit and talk and talk and talk and talk and talk. And eventually a decision gets made. But it's like OPEC. We'll agree to, our big decision today is to meet again in a month. And so we'll table these things. So you have to understand that. But the concept of working with the hospitals is critical. And what really is critical, that if the doctors really want to be a major part of this, they've got to get on these ACO boards, and they've got to take their job seriously. They've got to attend all the meetings. They've got to do their homework between meetings. And then the hospitals will let them run it. But if it looks like you're showing up a token for your token lunch and a little bit of discussion, and you leave 20 minutes before the meeting is over and arrive 20 minutes after it starts, they won't take you seriously. And they're quite ready to make all the decisions. Provide value at all costs. And I think the last one is to innovate and think like a customer. Before you decide how you're going to run your practice, what you're going to do, how would you as a patient respond to that? Would you like that system? You know, the biggest one is the telephone systems. I don't think there's a place in this country anymore, doctors groups, that has an efficient telephone system. And so is that what you would want when you call in? When you call in to Sears and get put on the phone for 30 seconds, a minute, 2 minutes, 3 minutes, well, somebody does that in your office, they have the same reaction. So just think like a customer. Albert Einstein once said, the definition of insanity is doing the same thing over and over again, expecting the same results. Well, we're not going to be doing it over and over again anymore. Well, what are the controversies? Let's just close up here. What are the controversies about this? The first, of course, is the legality of the act, and that's going to be pretty much decided by the Supreme Court. But as I said, the Democrats are going to try to drag that out for 2 or 3 years before it goes to the Supreme Court. The Republicans are pushing it to go tomorrow. The latest thing is they're trying to get 2 judges to recuse themselves from the court, the new one, Kagan, and who's the Republican? I can't remember now. But so there's all sorts of bantering going on. I think that if the court stays the way it is, the Republicans are successful at getting it to the court within the next 6 months, it could be repealed. But what does that do? Now we're back to 2008. Is that the way we want to practice medicine? Does anybody agree that disagree that some of these ideas aren't good ideas? So you say start again with what? I mean, the big key is you can't cover 40 million people without spending more money. So we're going to go back to that argument again. So repealing the bill is a very dangerous way to go here. Financing of the act. Well, this is the real weakness of the act. If you look here, they expect to get $500 billion from Medicare fraud. Well, even if there is $500 in Medicare fraud, they've been looking for it for 20 years, and they haven't been able to find it. And whether the fraudulent people are smarter than the government people, I don't know. But let's say there is $500 million in fraud. They've got to find that money. It's going to take a huge amount of money to hire people to try to find it, but they have been notoriously unsuccessful. But the whole bill is based on that. Now, what do you think will happen if they don't find that? Well, anybody remember the headlines in 1996? In the USA Today, it said the University of Southern California hospital, teaching hospital, is to close. Why? Because it ran out of money. And that was back in the HMO days when, and so now are they going to let USC, are they going to let John Peter Smith close? Other hospitals can't handle it. You guys don't even want the patients. They're not going to close it. Let's say JPS ran out of money tomorrow. They're not going to close it. Some of the other hospitals think, well, they could just come on over for a couple of days and we'll show you what it's like. You know, you're not going to close it. So what do? Where do they get the money? From the doctors, and transfer it to the hospitals. That's exactly what they did in 1996. That is when a lot of the subspecialists had a marked decrease in the reimbursement, especially the cardiologists, cardiovascular surgeons, neurosurgeons. Where'd that money go? To the hospitals. Then there was a group of hospital administrators, very narcissistic hospital administrators, came along and took credit for the improvement in the hospitals. Well, of course. It was like a stimulus fund. They just dumped money into the hospitals. Of course they're going to do better. Well, what are they going to do this time when the hospitals go under? Go back after us again. So I think that is the real major weakness of the bill. Now you hear about the CBO estimates that the bill will save money, but remember how this is done. The people in the CBO are like your sons and daughters who are really sharp business people, and they go work for the government. And they're about 30 years old. And they are great number crunchers. They know how to use computers better than anybody in the whole world. So you give them your data, and they punch it all in. They come up with this figure. But built into that is this, that there'd be a $500 billion reduction in Medicare. So if you take that out, it loses $350 billion. But that's the way those numbers are arrived at. The tax provisions, I won't get into these, but clearly there's a lot of taxes in this new bill, both on individuals and on companies. The FICA tax would go up from 1.45% to 2.35%. In companies, there's all sorts of new fees on the pharmaceutical company, the health insurance section, the insurers, an excise tax on the sale of any medical devices, and this one for the tanners, there's an increase of 10% on tanning services.